Hello everyone. In this video, we'll be presenting on structural and functional improvement following integrated optical coherence tomography guided cystotomy in 3 cases of intracystic hyperreflective material. There are no financial disclosures. Intracystic hyperreflective material is an optical coherence tomography finding which denotes accumulation of composite material in the intraretinal cystic space. The pathophysiology behind the appearance of this material accumulation can be a large microaneurysm which is consistently leaking into the cyst, or can be due to migration of hyperreflective spots into the cyst. Venkatesh et al. Have reported that the patients with DME with ICHRM tend to have a poor visual outcome even after aggressive treatment with medical therapy, which includes intravitreal injections as well as lasers. Now we will proceed on to the surgical technique for this procedure. With the help of microscope integrated OCT, multiple scans are done to analyze the cyst and to locate the puncture size. A 5-line horizontal raster is first performed to rule out multiple cysts or ICHRMs or septate cysts. Then a combination of cross OCT and single OCT scan is obtained to understand the locale of most dependent part of the cyst with access to the ICHRM. Following a standard ILM peeling that should cover the intended puncture site, a 38-gauge subretinal cannula is introduced into the vitreous cavity and the dependent part of the cyst is approached while monitoring with the OCT. While puncturing the cyst, the cannula tip in the vitreoretinal interface appears to be hyperreflective and may cast a shadow on the underlying retina. This needs to be differentiated from the dimple that is created on the vitreous face of the cyst cavity. The second case depicts a septate ICHRM where 2 punctures were required. After deciding the dependent part of the cyst, first puncture is given over the fluid compartment where dimpling of the cyst is visible, which collapses immediately. The second puncture is delivered over the compartment containing the ICHRM. Another case demonstrating the use of microscope integrated OCT and the technique of cystotomy. Following ILM peeling, the cyst puncture is done and monitored as in the previous case. The immediate collapse of the cyst is noticeable and the fluid component is resolved. The ICHRM will itself resolve with time as noted in the post-operative OCTs. With this, we'll proceed on to our cases. A 69-year-old gentleman presented with decreased vision in both the eyes. The patient had already undergone panretinal photocoagulation in both the eyes. In view of diabetic macular edema in the left eye with the best corrected visual acuity as 20/60, the patient was planned for left eye intravitreal bevacizumab. Even after 2 injections, there was no improvement in visual acuity and the OCT demonstrated an increase in the size of ICHRM with the evidence of contracture of the material in the cyst. On the angiography and OCT scan, a large leaking microaneurysm can be noted, which was responsible for the ICHRM. So, the patient was planned for pars linear vitrectomy along with ILM peeling combined with cystotomy and fluid air exchange. The best corrected visual acuity at 3 months of the first case has stabilized at 20/40 with no additional therapy for DME. The ICHRM had resolved completely. Another gentleman who had persisting macular edema due to branched retinal vein occlusion, post 1 Avastin and Ozurdex, the best corrected visual acuity was 20/30. In the subsequent follow-ups, the patient received another Ozurdex injection and focal laser to the microaneurysms. However, in the OCT scan, we can see that the ICHRM is compact along with foveal hard exudates. The patient underwent the same surgical procedure. The best corrected visual acuity at 3 weeks was stable at 20/30 and the cyst had collapsed. Another patient who was on highly active antiretroviral therapy had developed diabetic macular edema in the left eye and was advised intravitreal injection. However, the patient did not adhere to the treatment plan and the vision had dropped to 20/80 with the development of ICHRM on OCT. The patient underwent the same surgical procedure with the resolution of ICHRM in early course. At 3 months follow-up, the BCVA had improved to 20/40 without the need of any additional therapy with tiny pocket of residual SRF. It has been seen in previous studies that patients with DME who had ICHRM at presentation or developed the same during follow-up had a poor visual outcome. The The authors don't recommend the surgery for every patient with ICHRM. Progressive increase in the finding and lack of response to injectable therapy with loss of vision is the ideal situation to consider this surgery. The surgical technique used in these three cases presented by us suggests a possible role of ILM peeling coupled with cystotomy in particular cases. The chief role of integrated OCT is to identify the puncture site, perform the actual puncture, and monitor its success. Hope you have enjoyed the video and thank you for your patient listening.